All of the blood supply to the abdominal organs comes from just three arteries: the celiac trunk, superior mesenteric artery, and inferior mesenteric artery. They branch from the abdominal aorta at T12, L1, and L3 respectively. Let's start with the superior and inferior mesenteric arteries. Say this is the large intestine. You've got the ascending colon, transverse colon, descending colon, sigmoid colon, and then the rectum. We have the appendix, and that's the end of the small intestine, the ileum, where it joins up. Now the arteries are easy. It's really dumb. The ascending colon is on the right side, so it's supplied by the right colic artery. The transverse colon is in the middle, so it's supplied by the middle colic artery. The descending colon is on the left side, it's supplied by the left colic artery. Unbelievable. Would you like to take a guess as to what supplies the sigmoid colon? That's right, it's the sigmoid arteries. This artery supplies the top of the rectum. Yep, it's called the superior rectal artery. You see this bit where the ileum goes into the colon? You bet it's supplied by the ileocolic artery. Now here's the rule. If you take the splenic flexure, everything distal to it comes off of the inferior mesenteric artery, whilst everything proximal to it comes off the superior mesenteric artery. It is that easy. Now just for a few finishing touches, the ileocolic artery gives off an appendicular branch. The SMA also gives off a few small branches to the ileum and jejunum and other parts of the small bowel. And more proximally, it also gives off an artery that goes up to supply the pancreas and duodenum from below. Now I must admit I did simplify one thing in my diagram. These arteries don't just go straight to the bowel like that. Instead, they form these beautiful arcades that all anastomose with each other within the mesentery, which then give off these small straight vessels called vasa recta to supply the bowel. I just wasn't bothered to animate all that, and I also thought it would make the diagram a little more confusing, but just remember that that's how it actually looks. Okay, let's move on to the celiac trunk. Now the celiac trunk itself is a remarkably short artery. It only goes for often less than half a centimeter before it splits into three. This first part's very straightforward. Liver's on the right, spleen's on the left. Common hepatic artery, splenic artery. Makes sense. Now, this third artery in the middle here, it's the left gastric artery, but I've noticed students seem to find it more intuitive in this next bit if we start at the organs and work backwards. So that's what I'm going to do. Along the lesser curvature of the stomach, we have the left gastric and right gastric arteries. They form an anastomosis, which just means the arteries crash into each other. Meanwhile, on the greater curvature, we have the left and right gastro-omental arteries. Why gastro-omental? Well, because the greater omentum hangs off of the greater curvature of the stomach, and so these arteries supply both of them. Some people also call them the gastroepiploic arteries. It's the same thing. And from here, working out where they originate is easy. You simply connect them up. Left gastro-omental off the splenic, left gastric was the third branch of the celiac trunk, right gastric comes off the common hepatic, and right gastro-omental also eventually comes off the common hepatic. There's a bit more to that last one though. You see, this branch of the common hepatic artery actually starts off as the gastroduodenal artery, and that's because it splits into the right gastro-omental artery and this other artery which, well, if the right gastro-omental is the gastro part, well then this one supplies the duodenum and pancreas from above. In fact, it forms an anastomosis with the inferior pancreatico-duodenal artery coming off of the SMA from below. Now for a couple of finishing touches. If you look at the common hepatic artery, after it gives off that gastroduodenal artery, the rest is all for the liver. So from that point onwards, it becomes called the proper hepatic artery. The proper hepatic artery gives off a small cystic artery to the gallbladder. Finally, the left gastric artery gives off some ascending branches to the esophagus, and the splenic artery gives off a few short gastric arteries to the fundus. Finally, let's talk about venous drainage. Now, for the most part, the veins are exactly the same as the arteries. The right colic, middle colic, all of that's still there. But the superior and inferior mesenteric veins don't drain directly into the vena cava. Instead, the inferior mesenteric is usually a tributary to the splenic vein, and then the splenic and the superior mesenteric join together, forming the hepatic portal vein. Classic exam question, by the way. The portal vein enters the liver alongside the proper hepatic artery and the bile ducts. The three of them together are called the portal triad, and they can be found in the free edge of the lesser omentum. But why? Why does it do this thing where it all goes into the liver? Well, if you think about it, these are the veins that are going to be picking up all of the things absorbed by the intestines. There could be toxins, drugs, alcohol, but you don't want to dump that all straight into the systemic circulation where it can go to brain and kidneys and other organs. So instead, it's sent to the liver, which filters it and then dumps it via the hepatic veins into the inferior vena cava. And that's it. That completes the venous drainage of the abdominal organs. But while I'm here, I want to go over a few interesting clinical implications. Imagine someone had very bad liver disease like advanced hepatitis or cirrhosis. All that liver tissue is going to become really disorganized with scarring and fibrosis and regenerative nodules, and all the blood vessels going through it will become similarly disorganized and narrowed from fibrosis. All this blood is going to have a much harder time trying to force its way through the liver, hence portal hypertension. It all backs up and becomes really congested. It's like a massive traffic jam. And with that increased fluid pressure, the hydrostatic pressure, more fluid's obviously going to leak out, and that's why you get ascites from liver disease. Well, it's one of the reasons you get ascites from liver disease. The other reason, of course, is that the liver produces proteins like albumin, and so if you damage the liver, it's not going to produce as much albumin. And proteins like to hold on to water, and so if you don't produce as much protein, you can't hold on to as much water. It's called having a low oncotic pressure, hence also ascites. Another implication from the portal hypertension and the blood having this hard time going through the liver is it's going to try to find alternative routes back to the heart. There are 2 or 3 places in this diagram that form anastomoses with other veins that don't go through the liver. Remember earlier when I said the left gastric artery and indeed vein give off a branch to the lower esophagus? The esophagus is obviously very long, and it's covered in a network of small veins. The ones higher up in the chest are actually drained by the intercostal veins, which then go into the azygos vein into the superior vena cava. So in patients with liver disease, a lot of the blood might get shunted into this route through these esophageal veins that were never meant to handle that much blood. So they engorge, creating esophageal varices, which if ruptured can lead to a life-threatening bleed. Another shunt the blood could take is actually in the rectum. We learnt about the superior rectal vein today, but there's also a middle and an inferior rectal vein. And those of you who've done the repro block will know that they drain into the internal iliac veins, alongside the other pelvic and reproductive organs, and eventually make their way back to the heart. And if the veins in the rectum distend, that's why hemorrhoids can be a complication of liver disease. And thirdly, the plexus of veins that drains the abdominal wall actually has some communications to the portal vein, and they can also, of course, be drained via the superior epigastric veins, which then go into the internal thoracic veins into the subclavian, back into the heart. And as the blood tries to take the path of least resistance and it goes through this portosystemic shunt, you get these distended veins in the abdominal wall. This sign is called caput medusae, and you may remember it from your physical examination workbooks as a sign of liver disease. It all falls out of the anatomy.